Let's see how to approach a gastrointestinal case. To begin with, the history taking, name of the patient, age in years, address, occupation, date of admission, and date of examination. Then comes the chief complaints in chronological order. Then we have history of presenting illness. The main thing which we have to go through here is abdominal distension, pedal edema, and abdominal pain, and nausea and vomiting. These are the main symptoms with which the patient presents with. So we have to ask about duration, onset, progression, aggravating, relieving factor as usual. But in nausea and vomiting, make sure you have asked about episodes, number of episodes, the content of the vomit, or the blood. Is it blood tinged, or was it associated after how many hours of food consumption? Next, we have other symptoms such as heartburn, flatulence, hematemesis, melena, dysphagia, constipation, and diarrhea. Then, moving on, we have jaundice, and altered bowel habit, such as stool color, consistency. What about the stool frequency? Was it blood tinged or melena? The other symptoms, such as fever, weight loss, pain in oral cavity, hiccups, should be asked. From here, we have past history wherein we ask the usuals: asthma, COPD, TB, diabetes, hypertension, ischemic heart disease, seizure. After this, family history, then personal history wherein diet, appetite, sleep, bowel, bladder, any habits. One thing which is of significance here is alcohol. Make sure you have mentioned about alcohol units, so and so units per day, per week. Uh, then we have drug history, drugs frequency, duration. Summarize the main key positive findings in your HOPI. Then write few diagnoses based on your HOPI. After this, we have general physical examination. So and so year, old man or female, presented with moderately built and nourished, conscious, cooperative, well-oriented, time-place person. Then vitals, pulse, BP, respiratory rate, if it was irregular or regular. Pulse, make sure you have written the rate, rhythm, volume, character, wall thickness, radio-radial, radio-femoral delay. Then we have JVP, how many centimeters of water. Then other things such as physical examination, such as palarectocyanosis, clubbing, lymphadenopathy, edema. Make sure you are thorough with edema. And next we have BMI, weight, height, calculate BMI. Other head to toe signs of liver cell failure include alopecia, uh, feta hepaticus, that is foul smelling of breath due to collaterals which doesn't cross the blood over the liver, and the all toxic metabolites smell. You get that typical smell. Then we have jaundice, spider navy, that is dilatation of vein around umbilicus. Then parotid swelling. Systemic examination. Uh, for systemic examination, the order usually should what we follow: inspection, percussion, palpation, auscultation. We don't follow here because the preferred order it is auscultation ahead of palpation and percussion, because auscultatory findings tend to change post palpation. Then inspection, of abdomen mainly, shape, distension, was it localized or generalized, were the flanks free or full, skin over the abdomen, symmetry, umbilicus position, dilated veins, visible mass, pulsation, peristalsis, was there any scars or sinuses. Then we have palpation. We have superficial palpation wherein we elicit tenderness, guarding, rigidity. Then deep palpation wherein we have liver, spleen, gallbladder. Bimanual palpation of kidney, hernia. When you palpate deep structures such as liver, spleen, gallbladder, Make sure you mention about location, size, shape, consistency, the surface edge, and tenderness, and something about movement with respiration. Then we have to elicit direction of flow of blood for dilated veins, abdominal girth, if there is some hernia or not. Percussion, liver, spleen, drop space. Then we have shifting dullness, fluid thrill, puddle sign. We basically do puddle sign for ascites, shifting dullness to for ascites, wherein you uh, ask patient to tilt laterally. Once you percuss, you will see the difference in the shift of fluid inside the abdomen. Then we have fluid thrill. Apart from it, we go for auscultation, wherein we hear for bowel sound, root, any venous hum, or any friction rub. Then we examine scrotum, spine, also do rectal or vaginal examination. We just mention it, we don't actually do it. Then we have other system examination, wherein we mention about RS, CNS, and CVS. Most of the times it might be accompanied with some complication in severe cases, but usually no. Summarize the key points and findings, and write your provisional diagnosis.